Respected chairperson, teachers and my dear friends. The topic is troponin elevated, how to avoid the false positive trap. We go from ECG again to another ECG. There's a case one, a 58-year-old male who presented with acute onset chest palpitation and chest pain. On just a week back, on 31st of May, he had a palpitation by 30th evening 3 p.m. and then he was brought to casualty taken to a local hospital from where this ECG was taken. The ECG, I think it's not clear, the ECG, the rate is around 150 and you are not seeing a definite P wave. I have zoomed up version. If you look closely, the P wave is slightly or very proximally close to the R wave, so it's a short RP tachycardia because the rate is around 150. And the trop done in the casualty was on 31st, on the day of admission, was 42.9 nanogram per liter, and the reference range is 12.7 to 24.9 nanograms per liter. So is it MI is the question when you have an elevated troponin. And this was the ECG. The person, the casualty, aptly detected it. Adenosine was given and it was reverted back, and you can see in the ECG it's a short PR interval with a pre-excitation noted. So the question is, when the troponin is elevated, is it MI? That is a question, because that is the troponin is one of the commonest investigations done in the casualty now. Now we have a case 2, a 78-year-old woman with a history of hypertension, dyslipidemia and rheumatoid arthritis on medications with an active flare, presented with weakness, dizziness and atypical chest pain. ECG was showing no STT changes, but the high sensitivity troponin done in the casualty came to around 12,850 nanograms per liter, and the cutoff was 18. So is this again MI? The question that to be answered is whether it is false positive or not. This was an interesting cartoon that came up. When you have type 1 error or is false positive, that is the male is said to have you are pregnant. That is where it is false positive. That is the result or the test which intends to do is positive, and trop is where the major part of the trop is to detect myocardial injury. So troponin positive means it is myocardial injury and need not be MI. That is the take home message would be go from this topic. And the false negative is when the test is negative but then the patient is pregnant, as in this case. So troponin forms the structural component or the musculoskeletal component of the cardiac muscle, and the troponin T is bound to the tropomyosin and the troponin I is bound to the actin filaments, and this forms the part of the myocardial apparatus. And in any case of myocardial injury, you get an elevated troponin. And the fourth universal definition of acute MI, where you have to see it is a clinical evidence of acute myocardial injury, and troponin is a essential component for the diagnosis of acute MI as per the fourth universal definition of MI. And the value at least should be above the 99th percentile of the upper reference limit. This was brought in because high sensitivity troponin can detect even troponin positivity in normal individuals. It has to detect at least troponin positivity in 50% of the normal individuals. So that is why a value above the 99th percentile cutoff has been kept in case of high sensitivity troponin, with at least one of the following symptoms of myocardial ischemia in the form of symptoms of myocardial ischemia, new ischemic ECG changes, development of pathological Q waves, imaging evidence in the form of echo or other imaging evidences, or identification of coronary thrombus by angiography or an autopsy. So troponin forms an essential part of the diagnosis of acute MI, and it is ordered left and right in our casualty. So as we said, myocardial injury is represented by troponin positivity, and it's not the acute MI alone. So you have an ischemic etiology, you have a non-ischemic etiology, and when you go into the types of MI, the classical MI is the spontaneous MI or the type 1 MI, where you have plaque with fissure, rupture or erosion. And the secondary MI forms around 30 to 40% of patients that come to the casualty. This is in the form of a supply-demand mismatch in the form of coronary spasms. It could be coronary arrhythmias, as you say in the case 1 that we discussed. It was the arrhythmia which promoted a rise in troponin injury. So it can be classified as type 2 MI according to the new classification. So it is not myocardial injury alone. You have type 2 MI because patient had symptoms of chest pain along with ECG changes. Then you have other types of MI like MI without full biomarker evidence, where you do not get time to send a biomarker, or it could be related to the interventions that you do like PCI. If it is related to the intervention, it is called as percutaneous coronary intervention, it's type 4, and the other one it is related to CABG. So why high sensitivity troponin? It has higher sensitivity, but then as sensitivity goes up, the specificity comes down. But the important thing is that it can be used as a point of care investigation in the casualty level, and if the patient presents within 2 to 3 hours, that is as per the ESC guidelines. But our patients do come to the hospital by say 8 or 9 hours of chest pain. That is a problem. As per ESC guidelines, if the patient comes within 2 to 3 hours and you have a initial troponin value of less than 53, that was a cutoff they put. If the initial cutoff is less than 53, you can rule out MI, and if it is more, it can rule it. And then they have a rule in or rule out algorithms like 0 and 1 hour or 0 and 2 hours. By 2 hours, if the change or the delta change or the change in troponin, some people say it is 5 or some people it say 10. If it is less than that, again you can rule out MI. But that differs from the time of presentation of the patient. You have a whole gamut of conditions which can produce trop positivity, starting from myocarditis, sepsis, pulmonary embolism. So these are all actually true positives, and it's not false positives. The false positives are where the patient has truly an elevated troponin, but then there is no evidence of myocardial injury. That is what you have to. And in case of high sensitivity to troponin, you have conditions like age. When the age goes up, troponin can go up. Male sex again has higher muscle mass, so the troponin goes up. So you have a whole lot of conditions. Even in hypertension, the troponin can be high. The interference should always be considered when a laboratory result is unexpected or discordant with the clinical picture that you have. The false positive troponin, the true false positive troponin you will have is due to heterophile antibodies, certain myopathies. When you have rheumatoid factor positivity, it can interfere with the immunoassay, fibrin interference, hemolysis, elevated ALP, and analyzer malfunctions. So heterophile antibodies are antibodies that are poorly defined antibodies. This can interfere with the immunoassay. The chemiluminescence assay, that is what we use for the detection of troponin. These antibodies can cross-react with the antibodies that are used for testing the antigen kit we use, the antibody kit that we use, and so it can produce elevated troponin values. Fibrin clots, where there is incomplete blood clotting prior to the centrifugation, this can again cause raised troponin values. Alkaline phosphatase can interfere with the immunoassay and can cause raised troponin values. Rheumatoid factor, around 30% of the patients will have rheumatoid factor positivity in case of rheumatoid arthritis, and the autoantibodies that are directed against the immunoglobulins. So these can again cross-react with the antibodies that are used in the test kit, and this can again elevate the troponin values. And then the cross-reaction due to skeletal muscle myopathies, because there is a re-expression of the cardiac troponin molecules in case of muscles after injury, and then there is this antibodies again can cross-react. So how to deal with the false positive results? First and foremost is to evaluate the patient's clinical presentation. The clinical presentation has to be taken into context before you interpret a troponin value. Consider other possible causes of elevated troponin as we discussed. Assess for pre-existing conditions like comorbidities, and when in doubt, always go for serial measurements. And as Subusar said, don't go with ECG and don't go with troponin alone. The clinical context has to always be taken into account. Utilizing different assays, Sam has shown that when you use the usual assays that you use is a Roche high sensitivity 5th generation assay. You can use another companies like the Abbott one or the Siemens one if you're really in doubt whether the troponin is elevated or not. then that alternative troponin, then you can block this antibodies, this heterophile antibody blocking agents available. If you specifically contact the lab and ask them to redo it with this, again you can get a normal value. So the case 2 was a non-occlusive CAD, the high troponin in the range of 12,000, which remained the same even on follow-up. And so to conclude, suspected false positive results when you have when you have to suspect when you have a lab and a clinical discordance, and the result interpretation have to be analyzed integrating the clinical assessment including ischemic symptoms and the ECG changes, and the refinement of techniques and proper understanding of the patient can decrease false positives. Thank you.